Hello, hello, everyone. Thank you so much for joining this evening for our another subspecialty VMR, and it's going to be GI this time. And we do have amazing people from University of Minnesota joining us. Dr. Rahul Karna, who's a fellow in GI, and Dr. Suchapa, and she's a R3, and she's going to be applying for her GI fellowship. And let's just give her a warm welcome and also best wishes for her interview season. And with that, Dr. Karna and Sushapa, and we do also have the amazing Sarah Blaine as well as Hans supporting us with the whiteboard and scribing and the teaching point. Dr. Karna, would you like to say hello?
Yeah, hi guys. Hi. Thank you so much, Kushal, for the kind invitation, and thank you so much for the entire CP Solvers team. We are really truly honored to be here. I'm Rahul Karna. I'm a chief gastroenterology fellow at University of Minnesota. I'm interested in advanced endoscopy and going next year to Beth Israel Deaconess Medical Center in Boston for 1 year of fellowship. Thank you so much, guys, for the invitation. I'm truly excited to be here.
And hi everyone, my name is Sushapa. I'm a third-year internal medicine resident at the University of Minnesota. So like Kochal was kindly introducing me, I am going through the interview season for GI fellowship, so wish me the best of luck. Thank
You're a
you.
rock star, Shashapa. You're a rock star.
Thank you so much. And yeah, really honored to be here today. I've watched a couple of the clinical problem solvers sessions, and I feel like they're all very interesting cases. And I always get a lot of interesting learning points. So hopefully today's case that we'll be presenting will be helpful for the audience. And the goal is hopefully we'll also have lots of fun.
Yeah, I'm sure about that. And then Sarah and Dr. Hans, would you like to say hello?
Yes, a brave hello I'm right now in Canada, and yes, I'm excited for the GI. Let's start.
Yeah, and hi, I'm Sarah. I'm calling in from Atlanta, Georgia. I'm a medical student at Emory.
Awesome.
Hi, Sarah.
I
Hi,
usually
Dr.
like to,
Hans.
sorry about that. I usually like starting off with a small icebreaker question. And for today, I thought we would just go ask, like, what's your recent seasonal favor of ice cream with toppings? And I do know a lot of us love ice cream and it's GI, so I thought it'd be very apt.
I think I have to say, mint chocolate chip. I think that's gotta be my favorite. Really obsessed with that. Really love having those, and it's probably not good for my health and cholesterol, but can't resist those.
Rahul stole my favorite ice cream flavor.
I think Sushapa, that's why we vibe so well. That's why you're in GI, I am in GI because we have a common taste.
I feel like that's like the answer that I usually give because it's like a little bit unique but not too weird. But then like I don't know what to say now.
You could just say mint chocolate chip, and then I'm going to be saying the similar thing till very recently. Mine was that as well. And you should give a try to Dubai chocolate flavor from
Mhm.
Shake Shack. I actually chose my apartment because it's a mile away from that. And
So
then, yeah.
Dubai chocolate is probably comes close. I think it has to stand
Yes.
the test of time. Mint chocolate chip has stood with me for years. Dubai chocolate chip, it's a little bit recent. I will give it a couple of more years to see which comes on top.
Oh, you know what? The
Awesome.
other flavor that I really like is matcha, the Japanese green tea. And some of my friends are like into making ice cream right now. So they're like exploring with the flavors. So I'm like, I'm so lucky to be your friends. You're giving me free ice cream.
Yeah. Let's start the session and let's get going. Sarah, when are we ready? You want to?
All right. Okay. So, all right. So I'm just gonna start with the chief complaint. So for our patient, presented with epigastric and right upper quadrant pain for 1 week.
Dr. Karna, when you someone patient comes to you with complaining of epigastric pain and right upper quadrant pain, what are you actually thinking of? And what are the things you
Yeah,
want to know?
I think there are a lot of good information in here, even though it's just chief complaint. But if you actually dissect it down, you have, I would say, at least two good information. Number one, the pain onset of pain. It's been going on for 1 week. So it's not a chronic lingering pain, not like a subacute pain. It's probably acute to subacute onset of pain. That is your number one clue. And I think the second clue is the location of the pain, which is super, super important. Like whenever you think about abdominal pain, I always think of it in terms of like the quadrants. Here it's in epigastrium and right upper quadrant. So likely the origin of the pain has to be from the organs which are located in these areas, which are probably your stomach, pancreas, liver, and gallbladder or biliary tree. So it gives me that whatever is the inciting factor that has been going on for 1 week, and the pain is coming from one of these 4 or 5 organs.
And are you worried about the time duration? Is that helping you with trying to make a diagnosis, or would you want to know more?
No, I think there are few things that definitely come to your mind when you hear about abdominal pain going for 1 week. Like the things that will come up, you always think about inflammation in those organs. Inflammation in these organs, stomach will be called as gastritis, or there is a peptic ulcer disease. In pancreas, you will think about pancreatitis. In your gallbladders, you will think about cholecystitis, even though most of these patients typically present with pain for like few days, but I think 1 week is not out of park or unusual, I would say. So these are the things that would probably be on the top of my head.
Suchapa, do you want to give us the next hour quad?
Of course. So the history is that this is a 73-year-old male. He's presenting, like I said, with worsening dull, aching, epigastric, and right upper quadrant pain for 1 week. But he reported that he actually has been having it intermittently for 2 months. The pain score gets up to 8 out of 10, and at presentation right now it's 4 out of 10. It's not radiating anywhere. He reports some nausea but no vomiting. He denied any fever or chills. He said he feels kind of bloated and his pain improves with Tums and ranitidine. There's no clear exacerbating factor. And then the review of system, it's pertinent for chills, weight loss, fatigue. He noticed some rash on his chest and back. He has some eye pain and swelling. He reports abdominal pain, nausea, and jaundice.
This is pretty interesting. Whenever we think about patient presentation, we always have to think about demographics and we have to keep them in mind. Certain diseases tend to occur in certain demographics. So 73-year-old male, so he's an elderly male. There are certain diseases which tend to have propensity for the later age groups. We'll talk about later on. And the other thing is his pain is not actually acute, but probably like subacute kind of a pain. Then the next important thing is he's not complaining of any fever and chills. Not having fever and chills makes us a little bit better, feel a little bit better that this is probably not an infectious cause of pain. Improves with Tums and ranitidine. I don't know, to be honest, like if it's just like something bystander, if it's of any clinical significance. Maybe he has a gastritis or a gastric ulcer, and so that's why he's noticing an improvement with Tums or ranitidine, or it just may be a completely unrelated process. What I would say is a review of system. There are some important points in here. Number one, I would say, is weight loss. weight loss is a very, very important consideration whenever we have patients presenting with weight loss. It's a red flag sign in gastroenterology. We need to think about, is the weight loss due to decreased appetite, that the patient is not able to meet the caloric demands, or the weight loss is because of increased energy demand. That means the patient is having high cellular turnover, which can happen in malignancies or inflammatory diseases or autoimmune diseases. So these are very important consideration. The other important point here is the patient is having some rash on chest and back, as well as eye pain and swelling. So rashes on chest and back, I don't know at this point if it's related to the abdominal pain or not, but in medicine, we have always been taught about like there is a unifying diagnosis. So assuming that it's related to the abdominal pain, it tells me that whatever process is going on in the patient, it has some systemic manifestations. So systemic manifestations of GI diseases typically can occur either with autoimmune diseases, or it can happen with malignancies. Less commonly happens with gastric ulcers, cholecystitis, or acute pancreatitis. Do we have any more information on degree of weight loss, or any more information about eye pain or swelling?
For the weight loss, he had lost 15 pounds in around 1 month. And for the eye pain, so 8 months ago, he actually presented to ophthalmology after noticing some swelling and pain above his eyes. And he got a biopsy of the lacrimal gland, and it just showed lymphocytic infiltration, that it was kind of non-diagnostic.
Yeah, weight loss 15 pounds in a month is pretty significant weight loss, and I would consider it as one of the red flag symptoms, which points to me that probably something sinister is going on. Probably like either increased turnover, probably increased cellular turnover leading to increased energy demands. The second thing is eye pain or swelling. If we think about if it's related to the GI diseases, it points more towards an autoimmune kind of a picture, especially that the patient had some lymphocytic infiltration in his lacrimal glands. Lymphocytic infiltration of lacrimal glands can happen with SLEs. It can happen with rheumatoid arthritis. It can happen with Sika syndrome. It's also possible that the patient has some systemic disease, and GI manifestation is just like the presenting feature of the systemic illness. So a lot of possibilities. I think the case is wide open. Let's see if there's any clues in the past medical history, surgical history.
Okay. So for the past medical history, he has a history of hypertension, asthma, sleep apnea, BPH, chronic sinusitis, and for surgical history, he had cholecystectomy due to gallstone 3 years prior. Family history, his father had diabetes, his paternal grandfather had colon cancer, his brother has prostate cancer. He denied any history of autoimmune disease, cancer, acute or chronic pancreatitis, or thyroid disease in himself or his family. His current medication, he's on albuterol inhaler, Maalox, amlodipine, 10 milligram daily, aspirin 81 milligram daily, atorvastatin 40 milligram, empagliflozin 10 milligram, lisinopril 20, montelukast 10 milligram, tamsulosin 0.4 milligram daily. He has some allergy to Sudafed and ibuprofen. For social history, he reports that he's a social drinker, never really a heavy drinking history. He used to smoke cigarettes, but he quit 40 years ago, and he denied any illicit drug use. He is a retired electric engineer at one of the major companies. And then his vitals at presentation, his temperature was 98.1 Fahrenheit. His heart rate was 50, blood pressure 149/69. He was sitting 98% on room air, and his respiratory rate was 16.
So this is interesting. I think there are some clues in here. I don't think if there are a lot of obvious pointers. In past medical history, I don't think there is any clue to the patient's presentation. Hypertension, asthma, sleep apnea, BPH, chronic sinusitis. I don't think these can be related or can lead to in the patient's presentation. Surgical history is important. The patient has a history of cholecystectomy. Patients can have right upper quadrant and epigastric pain because of cholecystitis, or they can also have common bile duct stones. Now, since the patient is cholecystectomy, that at least takes one differential out, that the patient cannot have cholecystitis. However, a history of cholecystectomy does not rule out common bile duct stone, especially if it has been 3 years. Patients can form primary common bile duct stone, which can lead to intermittent epigastric and right upper quadrant pain and nausea. However, weight loss, rash on chest back, eye pain, swelling, these would be very, very unusual for common bile duct stone, and I do not expect to happen. Then in the medical history, in amongst the meds, I do not think there is anything significant. Family history, in the dad, he has diabetes, colon cancer. A family history of colon cancer would predispose the patient to colon cancer, but this presentation is probably unrelated to it. I do not see any history of autoimmune diseases, any history of acute or chronic pancreatitis. Patients with family history of autoimmune diseases, chronic pancreatitis are predisposed to pancreatic issues. In terms of social history, I think the only thing that I see significant is probably the history of smoking. If patient has prolonged history of smoking, that would raise concerns for possible malignancy. Like the vital seems to be, I think, pretty overall. It seems to be fine, except for weight loss, which we have discussed. Do we have physical exam?
Dr. Khanna, before we go to the physical examination, are you giving importance and significance to the smoking history for 40 years, and then there's a rash, and then seeing if it's a paraneoplastic? Is that becoming your top differential from your, like initially you were mentioning the rash could be an SLE or it could be something else, rheumatological condition, and now is it tipping towards malignancy? Is that what I hear you say?
Yeah, I think so. Like, the patient presenting with subacute smoldering right upper quadrant pain, and like, patient has weight loss, fatigue, rash. I think the differentials in my mind is probably autoimmune versus malignancy. Prolonged history of smoking definitely raises concerns for malignancy. Especially elderly patient is elderly as well, so age and smoking history would fit with that. However, it's very important, like, that the patient has had lacrimal gland swelling in the past, and the patient has had lymphocytic infiltration in there, which will point towards an autoimmune process. So I think these two are probably at the top of my differentials. I think, but we will need some more information in terms of physical exam and labs to move in one way or other. I would say both are probably at the top of my list.
All right, for a physical exam, so his weight is currently at 236.6 pounds. His baseline was 15 pounds above this. His BMI is 32.2. For exam, general, he was alert, oriented. He was in mild discomfort, but not in distress. For head, HENT, it was positive for icterus sclera. He had some swelling and pain above his eyes. He had moist mucous membrane. He had icterus underbelly of his tongue. There was no JVD. It was his ocular movement was intact in all directions. For cardio, it was regular rate, no murmur. Lungs were clear bilaterally. For abdominal, the bowel sound was positive, belly was soft. He had some tenderness at the right upper quadrant and epigastric area. There was no rebound tenderness or guarding. For extremities, there was no edema. His neuro was intact. And for the skin, he had some post-inflammatory hyperpigment macules on his back and chest.
So the physical exam with some good findings. The patient has icterus. So definitely the patient is jaundiced, and if the patient has icterus in the sclera, I can say with confidence that the total bilirubin should be greater than 2 to 3 at least. So I can hopefully we will know soon with labs. Then in abdomen, the patient has tenderness in the right upper quadrant / epigastrium, which makes me think about either pancreatic origin or probably something in the liver or in the remnant biliary tree. Since the patient is post-cholecystectomy, the patient cannot have any issues with the gallbladder, but remnant of the biliary tree, liver, pancreas, top of my list. And the patient has hyperpigmented macules as well. If it's related to this GI illness or if it's a systemic illness and now GI is the presenting issue, it also definitely makes me think about autoimmune diseases. As you were mentioning, Kushal, some of the paraneoplastic syndromes are also a possibility. Pancreatic cancer can present with skin manifestations, though not common. The usual presentation for pancreatic cancer is obstructive painless jaundice, but Trousseau syndrome, which is migratory thrombophlebitis, can happen with pancreatic cancer. The other things which we think about are probably like necrolytic erythema migrans, which is rashes on the body, which can happen with glucagonoma. That is another possibility. Other cancers, GI cancers sometimes can have systemic lymph node involvement. Stomach cancers can have that. I think that's what I would be thinking at this point.
One of them in the chat raised really interesting points, saying if the bradycardia in this patient, could it be because of any infiltrative disease? What are your thoughts on that, Dr. Karna? Or is that something which you are even considering now or not yet?
I'm not sure, he's 73-year-old. I don't know if it's truly a bradycardia or not. It's possible that his resting heart rate may be around 50s, so we don't know what his baseline heart rate is. Heart rate of 50 bradycardia can happen if there is a vagus nerve involvement, but that would definitely mean that the disease process is pretty advanced and infiltrative. So I think it's a little difficult to anchor on it. I will definitely keep at the back of my mind, but right now I think we do not have adequate information to relate bradycardia to some GI illness at this point.
Okay, for the labs, for CBC, the white blood cell count was 4.5, hemoglobin 14.7, hematocrit 42, platelet 173. For the CMP, his ALT was high at 303. Our hospital's normal cutoff is at 44. The AST was also high at 112, which is above the upper normal limit of 34. He had elevated ALK phos at 252, the cutoff is 150. His total bilirubin is 7, the cutoff is 1.2. His draft bilirubin was also high at 4.9. Albumin was normal at 4. His lipase was normal at 23. The cutoff is 60. His sodium was 143, potassium 3.4, chloride 108, bicarb 23, BUN of 8, creatinine of 1. Glucose was 94, calcium 9, and mag was 2. They also got a CA 19.9, which was normal at 10. The cutoff is below 34. For the chest x-ray, they didn't perform this. They performed an EKG, so it showed sinus bradycardia with first degree AV block, but this is similar to his baseline. Other labs that we got were the acute viral hepatitis panel. So the hepatitis A, IgM, and IgG were negative. The HBs antigen was negative. The anti-HBs antibody was positive. The hepatitis C antibody was negative. The ANA was 1 to 20, which was normal. Kind of not that significant. AMA was normal at 5. The cutoff is below 20. The F-actin 9 was normal at 9. The cutoff is less than 20. The total IgG is 1200, which is normal, below 1700. The total IgM was 120, which is normal, the normal cutoff being less than 300. The subtype IgG subclasses, the subclass 1 was normal at 277. The subclass 2 was also normal at 227. Subclass 3 was normal at 46, but subclass 4 was high at 205. The cutoff is above normal, being less than 86, but this is high, so it's not normal.
Yeah. So a lot of interesting findings in here and a lot of like good teaching points as well. I think let's talk a little bit about the patient's liver profile. I like to call it liver profile or liver enzymes rather than liver function tests, because traditionally it's like, we have been taught in medical school to call it liver function test, but actually liver function test would tell you absolutely nothing about liver function. It's a little funny. What I'm seeing is AST is approximately 2.5 times upper limit of normal. ALT is almost like 9 to 10 times upper limit of normal, and ALK phos is nearly probably like 1.5 times upper limit of normal. There's something like interpretation to liver profile. You have to always think about what is the pattern. I think a lot of hepatology is about pattern recognition, and liver profiles either fall into either a cholestatic pattern, hepatocellular pattern, or a mixed pattern. Here, there is a test called as R score or R factor, which was kind of like developed more for drug-induced liver injury. It was developed for, it's funny, like, it was developed late 1980s and probably like early 90s for drug-induced liver injury, to interpret what kind of a pattern does it fix in. And it's probably been validated only for that. However, we can use it here as well. And commonly we use it just to give us clues. And its R factor is, it's like patient's ALT upon like upper limit of normal of ALT divided by ALK phos by upper limit of ALK phos. We can calculate here in the chat box, but if I just grossly look at it, I would say it's probably going to be mixed pattern. The other thing is like, we always talk about bilirubin, and if it's a direct hyperbilirubinemia or indirect hyperbilirubinemia. As we predicted from the patient's physical exam, the patient's bilirubin came out to be high, so always go physical exam. The patient has predominantly direct hyperbilirubin. I think it's more than almost like 60 to 70% of total bilirubin is direct, so the patient has direct hyperbilirubinemia. There is a common fallacy in gastroenterology or in internal medicine that we think of direct hyperbilirubinemia being related to an obstructive or a cholestatic process. However, it may not necessarily be true. It can still be a hepatocellular process. It just means that liver functionality of liver cells is so impaired that they are not able to secrete bilirubin into the bile ducts. So from here, we can tell that the patient probably has mixed pattern of liver enzyme elevation, and the cells are inflamed in such that they're not able to secrete bilirubin into the common bile duct enough. So that's why it's spilling out into the blood, leading to direct hyperbilirubinemia. Some other good clues here as well. Patient's albumin is 4, which is very close to or close to normal. That means that patient's synthetic function is not impaired. It's not a chronic liver disease kind of a process. I think there is one of the lab tests here is CA19-9. I'm not sure why it was obtained, but I think we can discuss here about importance of CA19-9. CA19-9 is essentially a tumor marker, but it does not diagnose any tumor and does not rule out any tumors. It's good for serially following response to therapy for any tumor, but otherwise it does not give you any answers or any clues. Just because CA19-9 is normal, I cannot say that the patient does not have malignancy. If it was high, I still could not tell that the patient does not have malignancy because CA19-9 could be high in obstructive jaundice, common bile duct stones, or any cause that leads to obstructive jaundice. It can still be high. So for a patient who has mixed pattern of liver profile, I think it's important to rule out viral hepatitis, as Suchapa has very nicely done. Hepatitis A, B, V has been ruled out. This patient probably should also get some imaging. I think it would be reasonable to start with a right upper quadrant ultrasound. At some point, we should get that. I see that IgM levels have been obtained and IgG subclass 4 is elevated. IgG subclass 4 elevated can point towards autoimmune phenomena, something which is called as IgG4 related disease. It can point towards autoimmune pancreatitis. But still, like, it's kind of like non-specific. Like, we have patients can have autoimmune or IgG4 related disease with normal IgG4 levels, or they can have high IgG4 levels and still may not have the disease. So I think we should always keep IgG4 subclass elevated at the back of our mind, but I think it's important not to anchor on it exclusively.
And also, Dr. Karna, is that a diagnosis of IgG4 made with levels of IgG, or is it more like a biopsy specimen and having to see histopathology? Or is that something that you want next, or would you like imaging next, or how would you go for it?
It's kind of interesting. The IgG4 is elevated, but as I was mentioning, it's not diagnostic. Like you can have high IgG4 without an IgG4 related disease, or you can have a perfectly normal IgG4 and the patient may have IgG4 related disease. The diagnosis of any of the IgG4 related disease is a very clinical diagnosis. It usually combines overall patient's presentation. It combines like patient's imaging criteria. It combines what therapy patient has received and how the patient has responded to therapy. I think at this point, I think it's very, very reasonable to get like at least an ultrasound and see if there are any clues on the ultrasound.
So the right upper quadrant ultrasound, it showed that he had the cholecystectomy done and dilated common bile duct up to 10 millimeter. He also got other imaging. He got CT and MRI. So I think it would be fun if I could share the imaging and we could discuss what we think is the finding before I share the final read.
Yeah, I think so.
Okay. So I'm just gonna share my screen. Okay.
Are you able to move the image a little bit to the right?
Yes, sorry. Is this better?
Yeah, that's perfect. That's
sorry.
perfect. So yeah, I think what we are looking at is pancreas. I think somebody in the text said that post-cholecystectomy could be a cause. I totally agree. Usually, like common bile duct up to 6 millimeters is normal. However, in patients with post-cholecystectomy, you can have dilation of common bile duct, which is called as the reservoir effect. That can happen usually around 8 millimeters. If it's more than 8 millimeters, we tend to consider it as common bile duct dilation and think about possibly an obstructive process. What I'm looking at the imaging is the patient has pancreatic inflammation. It's the pancreas. You see how the borders are not sharp. Usually for patients with normal pancreas, you should be able to see very sharp demarcation of borders. There's haziness, which kind of goes into the mesentery. It's because of inflammation. I think there is a possibly a pancreatic duct. Whenever you are able to see pancreatic duct, which can possibly be dilated, it's kind of very difficult to say on this frame if the pancreatic duct is dilated or not, but I can definitely say this is pancreatic inflammation going on. This is almost like a very diffusely enlarged pancreas. I do not see, at least on this frame, a focal mass. I do not see any necrosis in the pancreas. What I'm just seeing is diffuse enlargement and inflammation of the pancreas.
Great. So the final read, it said that the pancreas looks like sausage pancreas, which is exactly what you said, Rahul. It's there's like swelling and like diffuse swelling and elongation of the pancreas, and there was pancreatic duct dilation. Okay, so moving on to other images, I have an image of the MRI.
Yeah, so this is probably like MRI and MRCP for the audience. MRCP is imaging of the biliary tree and pancreatic duct. MRCP does not use contrast. It usually uses it uses the bile duct to enhance the what you're seeing as the white is it's probably a common bile duct. And what I'm seeing at the bottom is, you know how common bile duct suddenly stops, you're not able to follow it afterwards. It's probably like a stricture at the end of the common bile duct.
Yep. So for this one, it says that there's biliary stricture at the pancreatic head. I have two other images.
Thanks for the wonderful images, Suchapa.
Of course. Sorry for the slow scrolling. I'm trying not to reveal the read.
Yeah, this is again an MRI image. What I can probably tell from this frame is Uh, just like inflammation of the pancreas, probably a focal mass. I can't tell without like in the full MRI, but probably a focal mass. If it is there, if it's in the head of the pancreas, and I would not be surprised because there is a stricture at the level of the pancreatic head. The pancreatic head is where the common bile duct joins the pancreatic duct to come and drain at the ampulla of Vater. So yeah, I think that's all I can see here.
So the read says there's an enlarged mass-like structure at the pancreatic head. All right, and the final image.
Oh, the MRCP image.
Mm-hmm.
Yeah, so this is the MRCP, which is after you do the MRI, you can reconstruct just the biliary and pancreatic tree. What we are seeing here is a very nice image of the biliary tree. You can see two Y-shaped structures. These are intrahepatic ducts, which come together and form the common hepatic duct and ultimately form the common bile duct. You see how the common bile duct is of like probably wide caliber, and where the arrow is pointing, it just suddenly narrows down to almost nothing. So it basically tells you that there is a structure over there.
Exactly. So it showed distal common bile duct stricture. So going over all the reads, there's evidence of intra and extrahepatic biliary ductal dilatation with a focal transition point at the distal common bile duct at the pancreatic head. There's two mass-like areas of pancreatic parenchymal hypoenhancement with intervening segmental pancreatic ductal dilatation. So one of the mass-like area was measured at 25 times 20 millimeter in the head, and there was another one in the body of the pancreas measuring at 20 times 22 millimeter. There's also mild inflammatory changes in the body of the pancreas, suggesting mild pancreatitis. There are segmental areas of the pancreatic ductal dilatation in the tail associated with atrophic parenchymal changes. There's stones in the dilated cystic duct remnant. There's no choledocholitis. The splenic vein was narrowed with early splenorenal collateral formation. So the patient,
Yeah.
oh, go ahead.
So I think like, I think what we have been thinking of, our differentials remain malignancy or an autoimmune phenomena, probably like an IgG4 related pancreatitis. It's like whenever there is a mass, it's always important to rule out malignancy in somebody who is elderly, has a history of smoking, has had weight loss. And however, there are like few pointers which tell that this patient could have had IgG4 related pancreatitis as well. This patient has like rashes on the body. This patient has eyelid swelling or inflammation, and the biopsy was positive for lymphocytic infiltration. This patient has had IgG4 levels which are high, and the imaging features are like, its imaging features could possibly be consistent with autoimmune pancreatitis. Autoimmune pancreatitis can present with either just like a diffuse enlargement of the pancreas, what was called as like sausage shaped. It's like the buzzword. It's commonly asked in medicine boards, gastroenterology boards, and maintenance of certificate exams that sausage-shaped pancreas is kind of like, very overall consistent with autoimmune pancreatitis. However, we should always consider malignancy at the back of our minds. Pancreatic cancer can also present as acute pancreatitis. So that should always be under consideration. I think it would be reasonable that we should pursue with biopsy of the mass to confirm or say if it's an autoimmune pancreatitis or if it is pancreatic cancer. I think that should be the next step. In current era, percutaneous biopsy has largely been replaced by endoscopic ultrasound guided biopsy, just because endoscopic ultrasound goes very close to the pancreas. You're able to put your endoscopic ultrasound probe near duodenal bulb or D2, and from there you can basically sample any area of the pancreas, like pancreatic head, or if you want to sample body and tail, you can do from the stomach. I think we should probably do that.
So the patient did end up getting an EUS endoscopic ultrasound. There wasn't any sign of pathology on the ampulla. A mass was identified at the pancreatic head, so an FNA was obtained. A mass was also identified at the pancreatic body, and another FNA was obtained there as well. There was dilatation of the common bile duct up to 13 millimeter. The pancreatic duct was normal in the body, but up to 2 millimeter in the diameter. And the rest of the pancreatic head was not visualized due to the mass. They also did an ERCP. The cholangiogram demonstrated distal common bile duct stenosis with upstream biliary dilation. Plastic common bile duct stent and plastic pancreatic duct stent were placed.
Yeah, endoscopic ultrasound, they found the mass, they biopsied it. I think finally we would know based upon the pathology what the final diagnosis is. I think my suspicion is very, very high for an autoimmune pancreatitis or an IgG4 related disease, but I will definitely look at the biopsy report to confirm. Pancreatic cancer is like one of the great mimickers, and IgG4 related pancreatitis or autoimmune pancreatitis really, really mimics pancreatic cancer in clinical presentation, in imaging findings, and sometimes on histology as well. It can be very difficult to differentiate between those two.
Awesome. So the pathology of the aspirates, it showed atypical epithelial cells seen in small sheets, glandular clusters, and a few single cells. While there is cytologic atypia in these cells, there's no nuclear size variation to the degree seen in adenocarcinoma. All of the findings are present in the background of significant chronic inflammation and stromal fragments with inflammation. Given the clinical history of elevated IgG4 levels and the degree of chronic inflammation seen in the aspirates, the atypical changes are most likely reactive in nature secondary to autoimmune pancreatitis. So the final diagnosis is IgG4 related disease with autoimmune pancreatitis and IgG4 related sclerosing cholangitis.
Pretty interesting. Yeah, IgG4 related disease really, really mimics pancreatic cancer. And as like the pathology report mentioned, the severe inflammation and chronic inflammation can lead to some distortion of like the polarity. It's more like the degree of inflammation was so severe that it's more likely to be an autoimmune pancreatitis, but it can be very difficult to differentiate between those two. Thanks to the pathologist for making the diagnosis. I kudos to them. It could really be really, really challenging. I think one other good point to consider is as Kuchal, you were asking about diagnosis of autoimmune pancreatitis earlier in the case, and I was mentioning how it is a clinical diagnosis. You see any of the features by itself here, even be it pathology, be it imaging, be it lab values, are not like pointing towards IgG4 related disease. You could never say with certainty that this is IgG4 related disease. The jury was still out till the end of the case. And that's why the diagnostic criteria for IgG4 related or autoimmune pancreatitis is clinical. It's completely clinical. The criteria is called as HISORT criteria. That basically combines supportive histology, supportive imaging features, extra organ involvement, like this patient has had eyelid swelling and some rashes, and also response to steroids. Response to steroids, if the patients are started on steroids for autoimmune pancreatitis and they do not respond well in terms of clinical and laboratory improvement, then we need to reconsider our diagnosis. So it's an important criteria there as well. And here we see, because patient's IgG4 levels were elevated, the patient probably has an IgG4 related pancreatitis, that is type 1. There are like two different types of autoimmune pancreatitis, type 1 and type 2. Type 1 is more related with IgG4 levels. Type 2, you do not see as much of IgG4 elevation. And they can just be overall pancreatic inflammation of a systemic IgG4 related disease. Because here we are seeing the patient has sclerosing cholangitis. And the reason we say the patient has sclerosing cholangitis is patient has biliary stricture as well, which was seen on MRCP. And I believe on the CT scan as well, they were able to see distal common bile duct stricture, and which points that patient also has sclerosis, or I would say strictures or beading, probably beadings. Beading probably is like a wrong word. But I would say like the patient has stricture in the common bile ducts because of IgG4 related disease.
Thanks a lot for bringing such a wonderful case, Dr. Suchapa and Dr. Karna, for the discussion. And Suchapa, what did you learn while taking care of this patient? And is there something which stood out to you the most?
So I actually had the opportunity to take care of this patient after he was given the final diagnosis. At that time, he was already like having much improvement in the symptoms after they started steroid. So he no longer had the severe abdominal pain. He was starting to regain some of the weight that he had lost. So he was feeling much better. But he did share with me that initially he was really concerned because he thought that he could have cancer. But it was kind of the guidance and the discussion with the teams that like were really clear about their thought process and the next steps in the management that kind of really helped him understand what's going on. And he really was appreciative of that.
Thank you. That's glad to hear that, he didn't really have the worst of the diagnosis possible, but yeah, and he was also feeling much better. Dr. Karna, did you have any two teaching pearls which you would like us to all to take away from this session?
Yeah, definitely. I think the most important thing that this case teaches us is not to anchor on one diagnosis. As we see how the case evolved from clinical presentation to labs to imaging and ultimately to biopsy, the jury was still out till the end that is it a malignancy or is it IgG4 related disease? So it's always good to keep the differentials wide and not to anchor on something. Second thing, I would say that clinical medicine always rocks. We are currently in an era where there is a lot of emphasis on testing, and sometimes we see in day-to-day lives that we tend to over-test, but ultimately the diagnosis, as we saw in this case, was clinical. It was like there were a lot of supportive evidence from like imaging, labs, there was supporting evidence from biopsy, but ultimately it was the clinical diagnosis, and only one test by itself could never have established the diagnosis. So always keep the clinical context in mind for any case.
Awesome. Thank you so much for that. Sime, did you want to share any one teaching point which you learned through the session, Sime?
Hello everyone, really amazing discussion. And after such wonderful teaching, I definitely have nothing to add. So I'll just emphasize on what Dr. Karna already said, that when a patient has a weight loss, is elderly, has smoking history, we should always consider malignancy as well as autoimmune disease. And then looking at the bigger picture is always helpful. Thank you, everyone.
That's
Thanks a
excellent.
lot. Yeah. Thank you so much, Dr. Karna and Suchapa, for joining us today. And thanks everyone for tuning in. We do hope that you have an amazing rest of September and talk to you guys soon. Bye.
Thank you so much, Kushal. Thank you so
Yeah.
much, everyone, for